the opportunity to share a little bit about palliative care in global health, and to share with you uh, what I think are some of the inequalities and inequities that we do see globally in terms of suffering, death, and dying. Now, I'm pretty sure that with the audience that we have here, everyone studying medicine and public health or global health, I think most people are acquainted with the idea that there are health inequities across the world. And we think about this in terms of differences in survival, differences in health outcomes, treatment rates, and cure rates. Today, I hope to share with you some that many of these inequities or inequalities also occur at the end of life, or with people who are living and dying of life-limiting illnesses as well. So it's a sad fact in our world today that even for those who are dying, or for those who eventually die of their diseases, they cannot escape inequality, right? And hopefully, by recognizing this current state of the world, we are able to put into action certain initiatives or plans that can address these inequalities for a better world ahead. Um, so I want to start by sharing this vignette that was published in the Lancet Commission on Palliative Care and Pain Relief. And this is a personal testimony from Dr. Rajagopal, who is a renowned palliative care practitioner in Kerala, India. And as you can see, he relates the story of Mr. S, who was a lung cancer patient at his clinic in Kerala. And this patient had experienced quite a bit of pain and was initially then presented to the palliative care clinic, and then was treated for the first time with morphine. And with the treatment of morphine, the patient actually had a lot of the pain go away, and was remarkably surprised and delighted at the obvious relief from the suffering that he was experiencing. However, when this patient returned the next month, uh, tragedy befell the patient in the form of a stockout of morphine, which commonly occurs in low and middle income countries. So with this, you can see here, Mr. S told us with outward calm, "I shall come again next Wednesday, and I shall bring a piece of rope with me. If the morphine tablets are still not here, I am going to hang myself from that tree." And you can see that while stockouts are no longer a problem for palliative care in Kerala, which happens to have one of the leading WHO collaborating centers for palliative care, we find that throughout most of the rest of India and in the world, we find near total lack of access to morphine to alleviate pain and suffering, as well as a similar lack of access to palliative care for patients with cancer and other life-threatening illnesses. In my lecture today, I will refer to this term serious health-related suffering repeatedly. And I just want to share that you can consider suffering to be health-related when it is associated or caused by illness or injury of any kind. And we consider suffering to be serious when it cannot be relieved without medical intervention, and when it compromises a patient's physical, social, or emotional functioning. And when we look at it from the perspective of global health, we consider 20 health conditions that most commonly result either in death or suffering that are severe enough to require palliative care intervention for people of any age. I've listed down here the health conditions that we believe when patients have these health conditions, they will very likely experience suffering that is severe enough to require palliative care intervention. And so this provides us with a useful proxy to measure palliative care needs across the world, right? So to put it quite simply, if I want to estimate how much palliative care need there is in the world, I begin by looking at measuring how much serious health-related suffering that there is. And in order to estimate serious health-related suffering, one simple way is to look at the number of people who are living and dying of these 20 health conditions throughout the world, who are also experiencing um, these forms of physical suffering or psychological suffering. And you can see under physical suffering, you have symptoms such as moderate or severe pain, weakness, fatigue, shortness of breath, vomiting, constipation, so on and so forth. With psychological suffering, you have anxiety, depression, delirium, confusion, dementia, disorientation, agitation, as well as memory loss. Right? Now, for some of us who may be clinicians or early career clinicians or even medical students, um, there can sometimes, as I teach students, there can sometimes be a tendency to look at, especially if you look at a patient's medical notes and you see that a patient has fatigue, it is often tempting to, in our mind, to think of it as simply tiredness, right? At least in terms of the English language, that is sometimes used as a synonym. But symptom like fatigue can actually be life-altering for a patient, and many of our patients who experience fatigue actually describe it as a complete loss of energy and capacity to actually do anything, including activities of daily living. So it is to have fatigue is in reality a very significant form of suffering. And likewise, to have diarrhea, especially persistent diarrhea or constipation, also constitutes a state of serious suffering, right? So not just pain. But before we move on, I thought it's useful to get us all onto the same page as to what is palliative care. And some of you listening in today may have had some experience with palliative care services or hospices services. Maybe you've had family or friends who've required these services. But I thought it useful to put us all on the same page. So very briefly, what is palliative care? So palliative care is holistic. It's person-centered care for people who are living and dying of life-limiting illnesses, as well as the people that care for them. So not just the patients who are ill, but also their caregivers. Palliative care aims to prevent and relieve suffering by identifying and assessing and treating sources of suffering such as pain and other serious health-related suffering, which I mentioned earlier on, due to severe illness. And it does this by identifying person-centered goals and preferences, which can be quite individual from patient to patient. It assesses and manages physical, psychological, social, as well as spiritual suffering throughout a patient's progression from the start of their illness all the way as the patient makes their way to the end of life care. And when they die, it also involves providing comfort and relief to the survivors and family members who are obviously grieving or bereaved. Okay. So you can see how it's all-encompassing. It is rather holistic, and it takes care of both the patients and the caregivers. Now, what palliative care is not, and I find it useful to hit these misconceptions right off the bat. Palliative care is not only for people who are close to dying, right? And I'll illustrate this point a bit more later on. It is also not reserved only for people who are dying of cancer. In fact, we find that the majority of people who require palliative care are actually living and dying of illnesses that are not related to cancer. And neither is palliative care giving up on treatment. And for many clinicians or doctors, sometimes there's a misconception that if we end up uh, referring a patient to palliative care, it means that we have failed. And so that can cause a large resistance towards providing patients access to palliative care, even if they need it. And most crucially, palliative care is not hastening death, it's not assisted dying, and neither is it suicide. Right? It's really a form of care that aims to provide relief from suffering as well as to improve the quality of life at the end of life. Now, who can benefit from palliative care? Many people can. Over 60 million people a year experience serious health-related suffering that can benefit from palliative care interventions. Okay, and people who live with cancer as well as other life-limiting illnesses have multidimensional symptoms, as I'll illustrate shortly, which can significantly impact their quality of life, and palliative care aims to address these symptoms and concerns. And for caregivers as well, caregivers of people who live with these life-limiting illnesses also face extremely challenging circumstances and the burdens of caregiving, and they often also need help from palliative care. Now, I often like to show this diagram to people who are new to palliative care because, especially the top diagram, it helps to dismiss the misconception that palliative care is really for the end of life, but only at the very end when there are no other treatment options available. And that may have been true in the early days of palliative care, but in today's world, we tend to adopt this model here. And what this shows you is that as the patient progresses from the point of diagnosis all the way to the end, we may find that initially all of our focus is really on the curative treatment or disease-modifying treatment. And the model of palliative care goes is that at the beginning, there may be minimal involvement of palliative care, but as we make our way progressing through the illness, we can simultaneously increase the amount of disease-modifying treatment that we offer, while gradually increasing the amount of supportive and palliative care for the patient and the caregivers. And even when death occurs, palliative care is still around to offer bereavement care. And this is useful to look in parallel together with the prognosis of many different life-limiting illnesses. For example, with cancer, we often have patients who are steadily deteriorating before we have a sudden deterioration, and this is when a point where you might rather significantly ramp up the supportive and palliative care that you offer. And likewise, even for heart and lung failure patients, they will have a steady deterioration trend, but will have periods where they will have more significant deterioration in their function. And for palliative care providers, these are transient periods in which we might increase the amount of palliative care that we provide to patients before reverting them to more conventional treatment as they improve, and then step in during episodes of deterioration. Right? So again, really the take-home message is that it's not palliative care really isn't a modality of treatment that's offered only at the end, but really throughout the entire lifespan of the patient. And different patients may require different levels of palliative care as well. You can have some patients who, let's say, who are well treated in the community at the primary care level, and they require some palliative support, which can be offered by general practitioners, primary care physicians. You can have other patients who are also doing well at the primary care level, but have certain episodes where they severely deteriorate and may require some consultations with palliative care physicians or being referred back to their general practitioners. And of course, you can have some patients who experience very complex illnesses with many severe debilitating symptoms, who may right at the onset require specialist palliative care, not only at the beginning, but throughout the course of their illness as well. So this is many patients who require palliative care, but not every patient requires a similar amount of palliative care. Some of them will require different amounts of palliative care at different levels throughout their lifespan. I mentioned earlier to you as well that palliative care is also not only for cancer. And you can see that in 2020, the Global Atlas of Palliative Care estimated that in terms of the worldwide need for palliative care for adults, only 28.2% have to do with cancer. But you also have a large number of patients who require palliative care, actually require palliative care because of HIV, right? And about 14.1% from cerebrovascular diseases, 12.2% from dementia. You still have patients who need palliative care due to injury, poisoning, external causes. And I think in today's world, with many conflict zones in Ukraine, in Gaza, etc., you can expect this percentage to increase as well. You also have degeneration of central nervous system diseases. Tuberculosis is still a problem in especially low and middle income countries. Then you have non-ischemic heart diseases. So again, really you can see from this diagram that the vast majority of patients who do need palliative care actually need palliative care not because of cancer, but from other non-communicable diseases or infections and injury. So thinking about the multidimensional needs of patients for palliative care, what are some of these needs? And as I mentioned earlier to you, palliative care aims to address a patient's physical, psychological, social, and spiritual suffering. So for many adult patients, physical suffering can come as a result of symptoms such as breathlessness, shortness of breath, nausea, vomiting, constipation, diarrhea, pain, or weakness, as well as insomnia, fatigue, delirium. But just as importantly, sources of psychological suffering include depression and anxiety. And not only for physical and psychological, these are the things that are most obvious and come most readily to medical practitioners as well as clinicians. But what often has an equally significant impact on a patient's quality of life are sources of social suffering, whereby many of these patients will not have any support needs for their activities of daily living, loss of finances, loss of employment. They may have psychosocial distress. There can be a lot of need for information in order to seek welfare, in order to seek support, in order to manage their day-to-day living or their illnesses. But quite crucially, there's the problem of loneliness and social isolation as well, which is often experienced, especially by patients with life-limiting illnesses that leave them bed-bound or homebound. Okay? There is also spiritual suffering, where patients, especially with cancer, neurodegenerative illnesses, etc., closer to the end of life, can experience existential distress. Patients asking questions like, why me? Why is this happening to me? What is the meaning of my life? If it all ends with a diagnosis like this, sometimes patients ask questions like, is this punishment for things that I've done in my life, so on and so forth. And all of that can lead to anxiety, distress, and contributes to suffering. Likewise, the lack of closure as well towards the end of it. And so that's from the perspective of patients. But for caregivers, similarly, many sources of suffering. If you've been involved in that act of caregiving, you'll know that it can take a toll on you physically. You can also experience insomnia, fatigue, weight loss, back pain is frequently a problem. So they also experience many sources of psychological suffering, including complicated grief and bereavement after their loved one has passed. Socially, because financial hardship, many caregivers have to give up their employment or convert from full-time employment to part-time employment. in order to do caregiving, right? And this is further complicated by the fact that the person who is now ill will cause the household to have greater expenses. There can be relational crises. There can be biographical disruption, whereby people now lose their identities. Let's say as a medical professional, they now lose their identity and simply become a caregiver. There is loneliness, there's social isolation, and spiritual loss. There's also faith crises, as well as a loss of purpose and meaning. So when we consider this very multi-dimensional source of suffering, it only makes sense that palliative care has to be delivered interdisciplinary, right? And we don't just mean between different medical disciplines or between different healthcare professions. It also includes people like chaplains and pastors who can provide pastoral care, community health workers, just general volunteers from the lay public, as well as social workers, but also undertakers as well as funeral home staff as well. All of these people are involved in providing palliative care. So really the key message to take away from here is that palliative care is not provided only by palliative care physicians or palliative care nurses. Really, we require a large group of both medical and non-medical workers to be able to provide supportive and palliative care to people, right? So it's sort of like a whole of society approach to help people address serious health-related suffering. So coming back to the burden of serious health-related suffering, well, how serious is this burden? The Lancet Commission in 2015 found that 45% of 56.2 million deaths globally experience serious health-related suffering. So almost half of all deaths have serious health-related suffering. And this is particularly bad in low and middle income countries. You can see that in low and middle income countries, of the 20 million deaths associated with serious health-related suffering, a high proportion of them are caused by diseases and health conditions that could have been prevented, so such as tuberculosis, such as HIV, such as injuries and accidents. And more than 95% of all the patients in need of palliative care and pain relief associated with conditions like HIV, premature birth or birth trauma, TB, malnutrition live in the lower and middle income countries. And you find that serious health-related suffering associated deaths in LMICs actually account for 81% of all deaths globally that are associated with serious health-related suffering. So this goes a long way to say that low and middle income countries disproportionately bear the burden of serious health-related suffering. But as you'll see later on, these are also the countries that have the least access to pain relief and palliative care. So in recognition of this serious problem, palliative care has been recognized as an essential component of universal health coverage. And in 2014, the World Health Assembly adopted Resolution 67.19, which actually sought to take steps to correct this typical oversight whereby many health systems across the world did not actually integrate palliative care or offer palliative care to their populations. And so the World Health Assembly resolution actually calls on member states to develop, to strengthen, and to deliver palliative care across all ages as an essential component of palliative care. And this was echoed again in 2017 when the universal healthcare definition was updated to include palliative care, and again re-emphasized by the Astana Declaration, which makes palliative care the fifth essential pillar of primary care. So again, this is where the updated definition of universal health coverage, as you can see here, includes and palliative care across the life course. Really then making the case that no nation, no UN member state can claim that they have achieved universal health coverage if they have not provided access to palliative care for its people across all ages. So really putting palliative care up front as one of the priority areas to achieve universal health coverage. So again, the need for palliative care globally uh, is growing, and this is growing as a result of an expected increase in the amount of serious health-related suffering in the near future. It's estimated by 2060, the number of people who are dying with serious health-related suffering will increase by 87%. There will be an additional 20 million people living in low and middle income countries dying of serious health-related suffering. Okay, and that corresponds to an additional 155% increase. More than 80% of people who are dying with serious health-related suffering will be living in low and middle income countries. And contrast that with the limited capacity and limited access to palliative care. Globally, only 14% of people who need palliative care will be able to receive it. So there is a huge mismatch between supply and demand for palliative care. And again, you can see that all show us that in terms of the increase, projected increase in deaths with serious health-related suffering from 2016 to 2060, you can find that every income group, every country income group will have an increase, but you will see here that the largest increases are expected in the lower middle income as well as the upper middle income groups. And another way of showing this, we find that in terms of increase, the percentage increase in serious health-related suffering across the world, you find that it's expected that from 2016 to 2060, for high-income countries, there's an expected increase of 57%. But for low income, it's an increase of 155%, lower middle income, 87%, upper middle income, 88%. So once again, this growth in the need for palliative care is expected to be borne disproportionately by the LMICs. And so what is expected to contribute to this growth in serious health-related suffering? What is projected is that this growth is going to be driven by an increase in cancer, in neoplasms, followed by cerebrovascular diseases and lung diseases, as well as dementia. So these four are expected to be the main drivers driving the global burden of serious health-related suffering from 2016 to 2060. But it's useful to point out that for low and middle income countries, especially low income countries, HIV and tuberculosis continue to be major drivers in the growth of serious health-related suffering. And keeping in mind again, these are conditions that we consider as preventable through good public health interventions. Okay, likewise for malnutrition as well. So, despite the growth in serious health-related suffering and the obvious need for palliative care, there are very stark inequities and barriers to palliative care across the world. Progress in expanding access to quality palliative care services across the world, unfortunately, has been slow and inequitable. So, palliative care researchers worldwide have come up with a framework to stage and evaluate countries' level of palliative care development, with the best levels of palliative care development as countries who have advanced stage of palliative care services integrated into their health systems, followed by preliminary stage of integration, followed by a generalized provision, isolated provision, simply capacity building activity. So at this stage, all you have is training courses, educational courses, limited training provided to general healthcare workers on basic palliative care. or no known activity where we think there are extremely limited or no palliative care services available. So in 2020, Clark et al. Had surveyed 198 countries across the world. And what you find is that if you combine the last three categories, you find that more than 60% of, of these countries have little or no palliative care services available. And it should not come as a surprise that the majority of the countries that are in these bottom three categories are actually the low and middle income countries, right? Uh, Again, the countries that tend to occupy the higher level stages of palliative care development typically tend to be the high income countries. And I think it's well illustrated in this map. Again, you can find countries with generalized provision or preliminary stage integration or advanced stage of integration. Uh, no surprise are countries that we typically refer to as either the global north or the high-income countries, with some notable exceptions in South Africa and in Mongolia, which is always an interesting outlier due to some very innovative steps taken by the government there to integrate palliative care services to their health system. But by and large, you can see the low and middle income countries here are still having relatively low levels of palliative care development. And so, as I've mentioned, there is great disparity between the need and availability of palliative care. It's most pronounced in LMICs, where approximately 80% of people who need palliative care live. And what drives this inequity of access to palliative care? Quite a lot of things, but one thing that often comes to mind is the fact that even till today, when we think about health outcomes, we think about measuring health outcomes, the metrics that matter for health, for measuring how effective a particular health system is. These health outcomes, as well as the focus in general medicine, tends to focus on survival, extending life, increasing productivity, improving cure and treatment rates. So it doesn't really give much attention to palliative care. It tends to neglect caregiving, and it also tends to neglect quality of life at the end of life. So if you happen to be a health policy maker and you want to be able to show the world that your health system is doing very well, it's likely you're going to prioritize those measures and those outcomes that are the main focus, which again includes improving survival, include improving health outcomes and curative rates, and you are likely to pay less attention to things like, again, caregiving or quality of death. And you will also find that even within countries, even within high-income countries, there is inequity of access to palliative care. People who are living in most deprived or rural areas, people from minority groups, marginalized and vulnerable groups, or homeless or incarcerated people, even in high-income countries, they tend to face the greatest challenges in accessing palliative care. Now, one of the things about palliative care is that this struggle to provide access to palliative care is not simply a problem whereby you can throw money at and say that you're going to invest a lot of resources into palliative care. You'll just build a lot of palliative care clinics or hospices and you will solve that problem. So it's not simply a matter of resource allocation, because one of the challenges or barriers to palliative care includes the misconceptions that surround palliative care. And this is because palliative there tends to be some negative stigma and or impression that's attached to it. It's often associated with death. It's often associated with giving up or abandonment. So many patients will and caregivers will shy away from it. Many doctors will hesitate to refer their patients to palliative care as well. And so there's this stigma surrounding death as well in many cultural groups, which can cause harm and can prevent people from accessing palliative care. And so the low awareness of what palliative care can provide as well. We've seen this limit referrals and acceptance of palliative care too. And likewise, whenever there's a misconception that palliative care is only for cancer, it actually limits the number of people who are referred to or people who accept palliative care. So, for example, if you have a condition, a neurodegenerative condition, uh, there can be instances where your neurologist feels that you don't need palliative care because it's not typically one of the conditions that they associate with palliative care because they're thinking, uh, more likely they're thinking of cancer as a candidate for palliative care. So just as an example, in one of the studies we did, uh, where we worked with patients with multiple sclerosis, which is a neurodegenerative disease that the WHO considers as requiring palliative care, we found that we outlined three particular scenarios, and you can find that for patients to be able to get palliative care, there has to be an alignment between patients who understand and are aware that they have needs that can be addressed with palliative care. You need a treating physician, in this case a neurologist, who can recognize those needs. And you also need to have access to palliative care services or palliative care physicians who are willing to accept the referral from the treating physician. So in scenario ones, we had patients who recognized that they had needs. They did approach their neurologist with their palliative care needs, and these needs were also seen by neurologists. But if, let's say, you don't have sufficient capacity for palliative care, and the palliative care physicians aren't willing to accept that referral, then it doesn't occur. In scenario two, you have patients who recognize that they do have many of these needs, which I mentioned to you earlier on, but without the recognition of a treating physician who can make that referral, the patient can never will struggle to actually receive and access palliative care, despite the presence of a palliative care physician who is willing and able to accept them and to provide treatment. And of course, in scenario three, you can have situations whereby you have treating physicians who are aware and willing to make referrals, together with palliative care providers who are willing to accept patients and provide treatment, but absent a patient who is willing to refer themselves or who is unaware that their needs can actually be addressed by palliative care, a successful referral and treatment will not occur. So we actually mapped out for patients with multiple sclerosis how the journey that they would have to undergo if they were to be able to successfully receive palliative care. And as I mentioned earlier on, a patient would have to seek treatment. They have to present themselves to their treating physician. The neurologist has to be able to perceive the needs and recognize that these are needs that can be treated with palliative care. And then you have to make a referral and referral has to be accepted. And the patient themselves must be able to accept that they are being referred to palliative care and that they can benefit from it. And of course, the palliative care physician must be able to deliver it to the patient. Now, in each of these pathways, numerous barriers can appear, and I've mentioned some of this to you already, and they can involve misconceptions about what is it that palliative care can provide, whether a particular need or particular symptom can actually be addressed by palliative care, so on and so forth. So essentially, the take-home message is that while you can have the right components of palliative care in the mix, the pathway to successfully delivering palliative care to a patient can be vulnerable to many barriers that get in the way. Now, another key barrier to treating patients' serious health-related suffering is the inaccessibility and unavailability of opioids across the world. Now, opioids such as morphine, as we all know, are crucial for pain and symptom control. And one might argue you will actually struggle to provide a palliative care service if you don't have access, as a clinician, if you don't have access to morphine and opioids. But we do find that across the world, there is unequal distribution of opioids, and opiate consumption and availability still remains proportionally concentrated in the global north. And so, for example, we'll find that in countries like Canada, the US, Australia, Western Europe, uh, they, well, they tend to disproportionately have the largest amount of opioids available to them, whereas countries like China, Vietnam, India, Haiti, and Nigeria have minuscule amounts of opioids that are actually available for the purposes of medical treatment. And so, crucially, it means that in terms of the percentage of estimated needs met, a country like Canada has enough opioids in order to meet its estimated needs by more than 3,000%, whereas a country like Haiti has only enough opioids to meet 1% of its estimated needs for pain control. So if you think back again to Mr. S, the story of Mr. S in India, it's not surprising that he struggles to get access to pain relief because in India, they only have enough opioids to meet 4% of all pain needs. So there's a huge um, uh, difficulty in getting opioids across the world. And the barriers to this inaccessibility of opioids can include a major barrier is the focus on governments and authorities on controlling illegal diversion of drugs and non-medical use. And while this is, of course, a real and significant concern, drug abuse, illegal drug trade is, of course, a significant public health concern. But what tends to happen is that governments and authorities put in place many very strict rules and regulations that have the result of actually crippling access to pain relief, crippling access to opioids for pain relief, making it extremely difficult for patients and healthcare providers to actually use opioids for pain relief. Of course, certain low-income populations may also have limited purchasing power to be able to gain access to opioids. But culturally and society-wise, there can sometimes be opiophobia. So there can be an irrational or disproportionate fear that if you use opioids, you will get dependent and addicted to them. So in that case, many patients reject opioids. Many healthcare professionals hesitate unnecessarily to prescribe opioids. Okay? And this can be also due to the absence of training on proper pain management, as well as cultural or religious attitudes towards the use of opioids and analgesics. So in order to tackle this, there's sometimes it requires a very culturally specific approach to address these misconceptions and fears as well. Now, another key factor that affects the development and implementation of palliative care is also the disparity in the production of palliative care research across the world. And we know that in order to design, implement, and to deliver good palliative care services, you actually need to have the right research evidence, right? It actually needs to be guided by evidence so that your interventions or your palliative care services are effective and culturally appropriate. And so to actually, it's really therefore important to have this evidence so that you are able to expand equitable access to palliative care. But much like everything else, we also find that the availability and production of this research is again highly concentrated in high-income countries, and in many low and middle-income countries, this research is non-existent whatsoever, which makes it difficult to guide the design and implementation of palliative care services in these countries. So in 2019, we ran a bibliographic analysis looking at palliative care research outputs within, even just within the Asia Pacific region. And we looked at, and we calculated the articles per million population. And again, you find that it is the high-income countries that disproportionately have the greatest amount of research, whereas middle-income countries, even halfway down the middle-income country list, you start to have null results because simply there is no research produced in these countries, much less for low-income countries. And this matters. I don't have this here, but we also ran analysis that looked at whether or not the amount of research produced correlates with the global rankings for quality of death across the world. And to no surprise, we find that the countries that have the most palliative care research produced are also the countries that tend to rank the highest on global palliative care development indexes, as well as the global quality of death indexes. Right? So those have been a large number of the barriers and the problems that we face in ensuring that there is equitable access to palliative care across the world. Now, very quickly, what are some of the recommendations to improve palliative care access? The World Health Organization has come up with the concept of the palliative care house. And as you can see, it rests on the foundation of having the right health policies that promote palliative care, empowering people and communities, on the bedrock of good research, as well as policies that promote the accessibility and the use of essential medicines such as morphine and opioids, good education and training for palliative care, ultimately leading to provision of palliative care services. I'm aware that time is running short, so I'll just quickly move through these recommendations. With regards to empowering people and communities, the recommendations really are to begin by improving the awareness of the general public. We call it the deaf literacy, as well as their understanding of palliative care in order to reduce the misconceptions that pose as barriers to accessing palliative care, and to really empower and facilitate community action. We find that the palliative care services that have the greatest uptake are those that have been co-designed and co-constructed together with communities, because these are the services that tend to be most practical to that specific community, as well as the services that are most culturally appropriate. We need good health policies. So we have to ensure that every country has evidence-based national palliative care policies, support people's right to access these palliative care services. There must also, of course, be funding that is allocated for palliative care services to be there. Obviously, there has to be strong promotion for research, especially research that looks into the unique cultural, situational, and socioeconomic context for LMICs. We need to have a research that takes into account input from patients, families, and communities as well as research that helps us look at outcome measures to develop, evaluate, audit, and cost and improve services. We need our opioids as well as essential medicines. So certainly, what key is to ensure that all countries have the palliative care medicines that they need in order to provide pain relief, as well as to address the other symptoms associated with serious health-related suffering. There needs to be education at all levels for all health workers, from community health workers to primary care providers, all the way to the specialist and consultant levels, on how to provide basic and specialist palliative care, as well as specialist palliative care workforces in especially LMICs. And lastly, really have this focus on improving access to palliative care services equitably for everyone, especially in LMICs and vulnerable populations, and as a whole, to have mechanisms that can monitor and evaluate the progress of how these services are being developed and implemented across the world. So really in conclusion, just to drive home once again, palliative care is not just for the dying, it's really an essential component of universal health coverage. If we fail to expand access to it, it really means that we will have a disproportionate increase of preventable suffering. And I think we can all agree that preventable suffering is something that we are all morally bound to really try to avoid or eliminate it. So we have to really work hard to expand palliative care provision and to integrate into healthcare systems. But this effort really has to be tailored to local contexts and cultural norms, because what might work in the UK, in Germany, might not work in places like Indonesia or Malaysia. And at the end of the day, if we are able to successfully implement universal access to palliative care, considering how the multidimensional symptoms and concerns that palliative care aims to address, we expect that there will be spillover benefits and beneficial impacts across other parts of the health systems. And as a whole, health systems around the world will have strengthened performance. So with that, I thank you all for your attention. Then this is my email address if any of you wish to send me questions or to make contact after this. Thank you.
Thank you very much to Dr. Mark Cheong for your very comprehensive. I think we just had a crash course about palliative care, within this short time period. I'm pretty sure a lot of us really appreciate learning about this topic. So we will open up to the Q&A session. Maybe if you all have any questions, don't be shy, just turn on your camera and talk to Mark, or you can also type in your questions in the chat box down there. Yeah, maybe I will start off, to start the engine kind of thing. Well, thank you again, because you have highlighted the inequalities in access to palliative care. I think this is often overlooked. And these inequalities in access to palliative care across the regions globally, particularly in the LMICs, right? So are you aware of any sort of global initiatives to address these inequalities, or maybe not at global level, or just national point of view, if you might be able to share some?
So there are certainly global initiatives that have been started, namely those that are also being led by the WHO, to begin actually looking at developing frameworks that will help to monitor progress of palliative care development across the different regions. So the training of primary palliative care providers, especially in LMICs. You have global initiatives that have begun to offer online training courses so that palliative care training can be made available to health workers in low and middle income countries as well. The Lancet Commission for Palliative Care and Pain Relief also proposed that especially low and middle income countries adopt an essential palliative care package that involves an economic or rather a cost-effective economical package of basic pain relief and basic symptom relief medicines, which are, well, for lack of a better word, cheap and can be safely deployed to many patients with serious health-related suffering. So many of these initiatives, but I think the general feeling is that progress, however, has been slower than what most of us would have been liked. And in some cases, in terms of the progress in the development of palliative care services, across the world. In certain regions, there has actually been regression, and so once again, it drives home the message that we do need sustained, concerted effort to keep pushing this agenda. Yeah.
Yeah, I believe researchers like you are the one who's pushing this agenda, right? To bring this agenda to the table. I think at the end of the day, all of us will also appreciate it because we will face that situation if we don't need that palliative care, someone we like close to us, there'll always be someone who needs it. Okay. One more question. Sorry. So, like, we know that financial costs is one of the biggest barriers, especially for implementing palliative care in LMICs. But maybe you could also point out like other main challenges of LMICs. I would be interested to know more about these social cultural things. And like maybe also you also address like some recommendations from the community. What examples of the community-led approaches that we can do? Yeah.
Yes, excellent. So I think when it comes to social and cultural, a lot of it revolves around many of the cultural beliefs or sometimes stigma around death. And so to put it plainly, I guess if if you belong to, let's say, a culture, or you're surrounded by people who believe that it is taboo to talk about death, or taboo to talk about issues related to death, it can be then very difficult to identify or to be aware that you may have certain needs at the end of life that could be addressed by palliative care. So in effect, then uh, you now have a barrier that prevents you from seeking palliative care. And in fact, these patients may then be hidden away from palliative care providers, so they are unable to actually provide that care as well. So, so this is where we actually need to work together with communities, with religious leaders to understand, well, what are the cultural considerations, what are the religious considerations around the end of life, how to care for the dying, what's the best way to approach families who are caring for people who are dying, so that we can actually craft interventions or services that are culturally or religiously appropriate and suitable for them. And likewise, getting the community involved. So this really does relate to why we need to get the community involved, because we've been doing some studies as well with some more rural communities, which are more conservative, let's say from the religious perspective, and we've proposed to them ideas about, for example, what if we came to your community and we offered palliative care nursing services to you, and in many cases, what the response we tend to get from these communities is that if you parachute healthcare professionals into our community and send them to our homes to care for us, we will turn them away because we don't trust them, because we don't know what they're about. And they start asking us all these really sensitive questions about death and dying and our family circumstances. Um, Instead, what they tell us and what we hear from our research is really these communities prefer to work with people that they have close relationships with. So they prefer for their family members who are dying to be cared for either by trusted family members or trusted community members. If there are any services to be introduced in their community, they want these services to have the endorsement of their local community leaders or their local religious leaders, which will then give them a sense of security and assurance that these services are legit. So this is where we have this sense that for us to be able to then effectively implement and deliver this kind of care in these communities, we have no choice but to work with them. The other angle to think about when thinking about community is that considering the large number of people who could benefit from palliative and supportive care, um, if we only look at healthcare workers as the providers of palliative care, we will actually never have enough of them. There will never be enough nurses. Even if you think about community health workers, there will never be enough community health workers to cater for this large number of people who need care. And so, what we actually need is to work together with community to figure out how can members of the community care for each other and provide support, i.e. palliative care, to each other as well. And this is really the core fundamental idea behind the concept of compassionate communities and compassionate cities, which aims to really raise awareness about death, raise awareness about the needs of people who are dying in communities, and find ways whereby communities can come together to care for their neighbors, family members, etc., in conjunction with interventions from healthcare professionals to care for all the people who are dying in their communities.
All right. Thank you, Mark, for sharing your great experience. I'm pretty sure you have a lot of backstories that you with all this research you've done in the rural areas, especially. So I think we are running a bit out of time. Yeah. Okay. If any one of you would like me to sign the slip for the Medis program, just send me an email, or I can also ask our other coordinator to forward that email to me, because I think most of you send the email to wtgh@stud.uni-heidelberg.de, right? Because my email is different from that. Okay, that's just announcement. Yeah, I saw one hand is up there. Samuel, do you want to say anything?
Yeah, my name is Samuel. I'm Dr. Cheong here in High. I just wanted to, thank you very much, Mark, for the impressive presentation and also the concern. You just reiterated about the community support system, which is very vital. Community engagement, community work, feedback is my area in terms of my study, and I'm using that for my doctoral program. Just a quick one: has there been any study at a global level to look at the community acceptability in terms of palliative care? Thank you very much.
Thanks very much for that question, Samuel. And actually, there are numerous studies out there. I think what tends to be an issue is that most of these studies, and rightly so, are focused on specific communities, and because it is difficult to actually do a study that generalizes across a wide variety of communities. And I think this is one area whereby it's probably right and suitable not to have large-scale generalizable studies, but rather have studies for specific communities that are able to provide us with very close to the ground, practical, targeted approaches for certain communities and certain religious groups as well. And I can share with you that this is incredibly important, especially even as we think about our ethical approaches to some of these palliative care scenarios or palliative care dilemmas. Like, for instance, if we go onto the whole bioethics model that's often adopted in the West, in Western countries, one of the key things is really about patient autonomy, and so a lot of the decision making that's being done in health decisions, especially at the end of life, you prize and you prioritize the patient's autonomy in making that decision. But we've had engagements with people from different communities around the world. And for some of these communities, they will tell you the cultural norm is that the patient would never make that decision by themselves. And if a doctor gives a cancer diagnosis to a patient, he's giving the cancer diagnosis to a patient as well as his entire extended family members, and that is acceptable. And in those cases, to insist on a service or an intervention that focuses on patient confidentiality and patient autonomy would be terribly misguided. So I think it's really crucial that we work at the ground level and have a wide variety of studies that can highlight to us all these different cultural considerations so that we can come up with targeted approaches. Yeah.
All right. Thank you, Mark. Do we have any other questions? Otherwise, you could also email to Mark if you maybe want to pursue research in palliative care, you know who's the expert now, or you can email me and I can forward you his email as well. So I think it's getting really late here in Malaysia. So thank you again, Mark, for this wonderful presentation. If you don't mind, I would like to also share this recording to some of staff members who are not able to attend this talk today. Yeah, thank you everyone, and don't forget to join in our survey. Maybe you have suggestions how to improve our elective track, and I'll see you guys next in next talk. When is it again? I think it's on the 19th of December. We will have it slightly earlier because then we will have like the Christmas break and everything, So thank you again and have a good evening to everyone. Yeah. Thank you
Thank you,
for
everyone.
joining. Yep.
Thank
Bye-bye.
you, Amima.
Bye.
Thank you.
Thank you. Bye.